When assessing a patient with abdominal pain or preparing for a surgical procedure, the first step is accurate localization. To do this, we divide the abdomen into specific zones. Today, we are exploring the topographic division of the abdomen, the muscles of the abdominal wall, and the clinical area you must navigate during a paracentesis. For a quick clinical assessment, we use the 4 quadrants system. These are right upper, right lower, left upper, and left lower quadrant. This grid is defined by 2 primary planes, the median plane, which runs particularly through the midline, and the transumbilical plane, which passes horizontally through the umbilicus at the L3, L4 vertebral level. The 9 regions. For more precise localization, we use 9 regions. Particularly, these are bounded by 2 midclavicular lines. Horizontally, these are defined by subcostal plane superiorly and transtubercular plane inferiorly. From superior to inferior, the right to left, we have right hypochondrium, epigastrium, left hypochondrium region, right lumbar, umbilical, and left lumbar region, right iliac fossa or right inguinal, hypogastrium, left iliac fossa or left inguinal region. This is the quadrant, right upper, right lower, left upper, and left lower quadrant, divided by median plane and transumbilical plane. This is the 9 region. These are divided by 2 midclavicular plane and subcostal plane superiorly and transtubercular or intertubercular plane inferiorly. The structural integrity of this area is maintained by 4 primary muscles, very particularly on either side of the midline is rectus abdominis muscle. This is rectus abdominis muscle. Moving from superficial to deep on the lateral aspect, we find external oblique, internal oblique, and transversal abdominis muscle. Understanding this data is critical for understanding surgical entry. Let's apply this anatomy to a clinical procedure, paracentesis. This is used to withdraw excess peritoneal fluid. Whether it is a needle for a procedure or a knife wound, the sequence of layer penetrate is vital for a clinician to know. In midline approach, these structures are based in order: skin, superficial fascia, superficial fatty, gamba fascia, and fibrous scapula, and linear ava, the fibrous structure where the muscle aponeurosis meet, and fascia transversalis, extraperitoneal fat, and finally, parietal peritoneum. For the flank, if we take a flank approach, the anatomy changes because we are moving to the muscular belly rather than the fibrous midline. The sequence became skin and superficial fascia. The superficial fascia is scapula fascia and gamba fascia. Gamba fascia and scapula fascia, and external oblique muscle, internal oblique muscle, transversal abdominis muscle. Then we hit the deeper layer, fascia transversalis, extraperitoneal fat, and parietal peritoneum. So, understanding these topographical boundaries and muscular layer ensure precision in diagnosis and safety in clinical practice. If you found this anatomy breakdown helpful, subscribe for more clinical deep dives. See you in the next lesson. Here are my references. Thank you very much.